Hi, this is Larry Bauer, Chief Executive Officer of the Family Medicine Education Consortium, and I'm excited today to be talking with Dr. Saria Saccocio, who is a family physician, and she is Department Chair of Family Medicine at the University of South Carolina, Greenville, and also Ambulatory Chief Medical Officer for Prisma Health. Dr. Saccocio, thank you for joining today.
Oh, my pleasure. Thanks for inviting me to the show, your podcast.
Absolutely. So I'm also joined by Allie Abel, who is a fourth-year student at Albany Medical Center. Welcome.
Thank you, Larry.
So Allie, I'm going to turn things over to you to get things started.
Sure, thank you. So Saria Saccocio, how do you like to be called? Dr. Saccocio?
Well, you can call me Saria. That's fine. We're among friends here.
Okay. So we like to ask all of our interviewees where they grew up and what led them to medical school. So could you maybe tell our audience that?
Yes, we certainly have our own story, that's for certain. I claim to be a Midwesterner. That's where my family is from, and I spent my early years. However, for the most part, I grew up in Florida, and that would be Central Florida to be exact. And I was in Florida for many years and then moved on up to the southeastern seaboard and back and forth throughout, and now live in Greenville, South Carolina.
And then led you to medical school.
And to medical school, yes, that's the other part of the question. I didn't grow up with a family of means, and I recognized early on with challenges in my family environment that it was important to get a job and to be able to depend on myself, to have a career that would certainly pay the bills and keep a roof over my head. And so for those reasons, I looked into professions where an education could take me to an experience that I would love and have passion for, and at the same time would give me a paycheck that could pay the bills. So I was always very interested in science. However, growing up in a trailer park, there are very few of us kids in the neighborhood who end up going to medical school. So I always had my backup plan, numerous in fact, but something always related to healthcare. And I just worked really hard, and gratefully, I had the privilege to attend University of Florida, and it's been a wonderful opportunity to get more involved in the healthcare profession and to serve others. But it really was to connect with individuals. I've always considered myself a people person, and relationships are at the core of what serves my personal interest in life and what drives me to connect with society.
Mm-hmm. And then when you went to medical school, did you know that you wanted to go into family medicine, or what kind of led to that decision?
I knew for many years that primary care was for me. And I remember the moment after my first year of medical school that I knew I wanted to be a family physician. And it was in Kansas City at the National Conference for Family Medicine residents and medical students. And within a couple of days of being surrounded by people who I felt were just like me, I thought to myself, I have found my people. This is my future. This is what being a doctor is all about. So ever since then, I have been a hardcore family physician with a passion for family medicine and for learners who also share that same interest.
Wow. Yeah, that's awesome. I feel the same way about the Kansas City conference. It's amazing. And so in medical school, did you have a mentor that led you to going to this conference, or what made you decide to go to Kansas City in the first place?
I'm thankful that I attended a medical school within a state that strongly supported primary care and family medicine specifically. The Florida Academy of Family Physicians was passionate about getting their medical students in the state to the national conference because of that incredible experience that it offers and that real life experience to connect with others with similar views and similar interests in how we take care of patients. So again, I'm thankful for Organized Medicine for sponsoring and investing in the future of family medicine.
Awesome. And then so where did you end up in residency, and where did your career take you after residency?
Well, in my life, family has always come first, as I'm sure it does for many people. And my fiance at the time still lived in South Florida, and so I quickly identified a residency program in the same geographic location and was blessed to match at the Jacksonville Memorial Family Medicine Residency Program in Miami, Florida. I spent 3 years there and enjoyed the opportunity to learn and see what it's like to practice family medicine with a large Hispanic community and Haitian community. There was such diversity. I'm sorry about the noise in the background. I'll have to answer that again. Hold on. Okay. So do you mind if I just pick up where you
Sure.
asked me about? Do you mind just asking the question one more time? And then
Yeah.
I'll restate. Thank you. Sorry about that.
No problem.
Challenges are working from home.
I know, yeah. Where did you go to residency, and then where did your career take you after you graduated from residency?
Yes, so family has always been important to me and led me to prioritize where I chose residency. I was blessed to match at Jackson Memorial Hospital in Miami, Florida, had a tremendous experience to learn inner city medicine with an incredibly diverse patient population. And from there, I was adamant that I wanted to start a micro practice. For those of you in the audience who are familiar with Dr. Gordon Moore, I was inspired by his model of in-person and close contact with patients and serving their needs across a broad scope of family medicine. So upon graduation from residency, I started my own practice in Fort Lauderdale, Florida. Some people thought I was crazy. Others thought, well, I guess you'll learn whether it works or it doesn't work. And so from that point on, I spent my last year of residency preparing to be a small business owner. I brought my mother down from Georgia, and we opened a practice together. I had no other employees. She did the front office, the back office. I did the nursing and the doctoring and everything in between. I took care of patients in the hospital, in the office, hospice care, as well as home visits, and had an incredible experience. And I'm, again, so grateful for learning from peers and colleagues who taught me along the way, other small business owners and solo primary care physicians in the community. And it taught me quite a bit about business of medicine. And when I share this story with medical students and residents, I prepare them by saying about 85% of my learning capacity for the first couple of years out of residency was spent on the business of medicine. Because gratefully, I already had that medical school training, and that was very helpful in the residency training to be a physician. But wow, I had so much to learn, and learning is indeed what I did. Shortly after having 2 children, I recognized that it was important to me to find a smaller community experience for my family to grow in. And I was also very passionate about teaching. And after working with medical students and residents in South Florida, I jumped on the opportunity to become an associate residency director for the Floyd Family Medicine Residency Program in Rome, Georgia. It was an unopposed residency program in Northwest Georgia and gave me a great perspective of what it's like to train physicians to work in communities where they may be the only doctor and the only healthcare provider. I also enjoyed participating and serving the community in the sense of the value of public health And as a family physician, I feel truly that is who we are and what we've been trained to be. And so at that point, I went to school at University of North Carolina in Chapel Hill to get my master's in healthcare administration, their executive program, and found myself in a new position as a chief medical officer in a health system in Danville, Virginia. And so this was a new world for me. I'm going from solo practice to academics, and then taking what I've learned and creating a healthier community in the town that we lived in Danville, Virginia. And then I have found myself back to the South in Greenville, South Carolina, where I was recruited to be the chief medical officer of Bon Secours St. Francis in Greenville. And I enjoyed the same experience, but it was primarily focused on the inpatient side of medicine. And I found what was missing in my fulfillment as a family physician was the connection and the continuity between the hospital and what happens before and after, and getting back to my roots, if you will, as a family physician. And so from that point on, and where I currently find myself as the ambulatory chief medical officer for Prisma Health and Department Chair of Family Medicine, is exactly where I want to be. And that's in the middle of a community to support the needs that are comprehensive and continuous across every experience of life and phase for patients and families.
Wow, you've had a lot of different experiences. So can you describe the organization of Prisma Health, what their mission is? And you kind of told us a little bit about who they serve, but just maybe a little bit more about Prisma.
Maria, did we lose? Saria, did we lose you?
Oh, I'm here. I was on mute. So I'll pick up from there. I did hear the question. And
okay.
what I'd like to share is that I really enjoy working at Prisma Health, the healthcare organization that supports our medical schools as well. We're a system that reaches across about half of South Carolina. And we have 2 medical schools with the University of South Carolina, Greenville, as well as our Columbia Medical School. And our catchment area and the people we serve is approximately 1.1 million patients. And we are a highly value-based organization and continue to grow in that direction. I'm the first ambulatory chief medical officer that our organization has had. And I think it speaks to the focus of population health and just how important the ambulatory space is in regard to patient care. We recognize that it starts with prevention and wellness, and then movement towards taking care of the patient in all settings across their lifetime. So for that reason, I am, again, privileged to work with my colleagues. We are truly physician-led. We have over 2,000 physicians in our organization. We have quite a large medical group. We do have independent physicians in the community, but it is heavily employed in South Carolina. So I can also share with you our really our purpose, and that's what we're about. Our purpose is about inspiring health, serving with compassion, and being the difference. And this is more than a plaque on the wall, and it's something that, frankly, I start every department meeting with and recognize our individuals in our department and through our healthcare teams that demonstrate how we inspire health in our communities and what's different about what we do, and maintaining that patient connection, which in some ways we've been incredibly challenged through this COVID-19 era, where we may be separated by video and by phone, but still connecting with others, and how we're different and how progressive we've been And I'm sure we'll have time to talk more about some examples of how that's worked in our healthcare organization. But I'll recall several weeks ago where literally within 24 hours, we set up telehealth with our own platform and started delivering care that in the past we would have depended on others to do for us.
Saria, I'm wondering if you could go back to when you began with Prisma. Could you share with us what you had to do to build your team, to grow your culture to what you have today?
Yeah, sure. And it's interesting. Anytime you're in a new position that has never existed before, the upside is there's no comparison. And also the challenge is sometimes helping to paint a landscape or a portrait of what it can be like where these services didn't exist before. And while telling a story is so very helpful and critical as you're engaging and getting buy-in from others, but it's sometimes more essential for folks who've never experienced outpatient care, who perhaps don't recognize initially or have been focused on primary care as the core of what we do and how we take care of patients and how we remain healthy, to help build that story. So we first started with our data, and we are extremely transparent in our organization about sharing this data and recognizing that about a third of our population now is in a value-based contracting setting. We recognize that we needed to quickly progress and find ways to expand quality of care and influence what that looks like and to support our providers and healthcare teams to be successful from that perspective. So I remember when I first came to the organization, I scheduled numerous meetings with individuals who were working with the organization in quality, in nursing, in informatics, because what I've learned is when you surround yourself with a team of geniuses and subject matter experts, then incredible things can happen. So what do I mean by that? We quickly identified what we refer to as our ambulatory team. And on this team, we have a data scientist to help us not only pull the data together, but to help us analyze and identify where is there variation, how are we recognizing where high performers are, where those teams are performing extremely well, and what resources may be missing from other practices. Because we recognize that every patient-centered medical home is unique, yet we've identified that those key drivers can help everyone. So that's why that data was so very important. We also have experts in process improvement. So interestingly, our leader for quality is an attorney by nature. And what he brought to the table was a gift of communication and being able to articulate two groups to get buy-in across all different specialties to bring us together. And of course, we certainly couldn't do this work without our nursing leadership, nurses who understood the scope and the practice of the outpatient space and how we can work together with everyone working to the top of their license. We have a director of optimization. So in our system, we've recognized that there is so much to learn across all of our practices and within groupings, and primary care is a perfect example of that. And our person, Katie, she has been able to help us optimize across departments, take those best practices that have been learned, and then cross-pollinate across our healthcare teams to create success. And we've also since added, because of all the work that we're doing in developing a calendar, if you will, of curriculum to follow for our high priority areas, an incredible and invaluable team member as a project coordinator. So Kelly is by training a middle school teacher, and she has added incredible value by being able to help us connect with individuals and understand different educational techniques to not only get the message out, but in a way that people can understand embrace it and incorporate it into how they learn themselves and how they teach patients to take care of themselves. It's quite a team, I must say, and I'm very proud of what they bring together so that we can take care of this entire organization.
And I have to say, I'm very impressed with just how eclectic group of people you've brought together in your team.
Well, and I believe it takes an openness. And sometimes where we're challenged as physicians, and I experienced this early on in training, was that as physicians, we're trained that we have all the answers, or at least traditionally speaking, we were taught that. So if you didn't have the answer, chances are perhaps you were missing something, and perhaps it was a weakness or a fault. And as family physicians, at the same time, we're trained to connect and collaborate with others when we need help and support to manage certain special and unique conditions. We, I believe, are some of the best trained physicians to grow teams and to gather individuals and to be open to what people offer to the table, because you can't do it alone. This is something we do together, and you have to be able to recognize those gifts and talents that others bring to the table to solve solutions and create solutions.
You mentioned 5 priority areas. Could you comment on those?
So our priority areas are focused on where our greatest needs are within the health and disease state of South Carolina. Like many states, South Carolina's #1 cause of death has been cardiovascular in nature. So we have since laser focused on hypertension and diabetes, as we know both of these are cardiovascular related and have a tremendous impact on death rates within our state and quality of life of South Carolinians. And we have also begun to focus on cancer, of course, because that's the second leading cause of death in South Carolina. So we've done a tremendous amount of work around breast cancer screening and colorectal cancer screening. In fact, our screening rates are in the 90th percentile and above at this point. So we're very proud of some of that work we've been able to contribute to our communities and capturing our audience and engaging them in a way that they understand that screening can actually help save their lives. And then that 5th metric that we focus on is behavioral health. Depression is rampant, and now more than ever with what we're experiencing with COVID-19, it's so critical that not only are we connecting with the physical health of our patients within our communities, but also the mental health that they are experiencing and what status they're currently at. Because when you put these two together, we know we create the healthiest community.
Great. Have you found any way to engage patients, either as advisors or to have a process for engaging them in the planning and the evaluation of what you do?
Yes, in fact, that has been a very strong focus for our organization over the last couple of years. For all of our facilities now, we have patient and family advisory groups. And though I've described to you our operational team that we refer to affectionately as the A team or the ambulatory team, we quickly recognized it was critical to have a group of individuals that we could then take these ideas operationally and bounce them over the wall to see, what do people think? Does this make sense? Are we connecting with what matters most and what is most practical for our communities? So for that reason, we developed a primary care council. So through our clinically integrated networks within our organization, we have stood up a primary care council. And on that council, we have patients that represent, for example, one was with the NCQA and had an incredible amount of knowledge about quality and what healthcare should look like. So a highly educated and well-informed individual in healthcare. And then we also added another patient to our group who was, well, who is in the millennial group, who is in his 30s and is actually involved in technology for his career. And he's offered a completely different and unique perspective of where our focus should be and how are we reaching individuals in our communities that are not necessarily your traditional primary care, relationship-driven individuals, but perhaps a younger generation that what we're hearing, perhaps they don't value that relationship as much and why they feel that way.
That's great. So
may I ask one question?
Go ahead.
How does the primary care counsel the patients communicate with you or with other leaders in the group, and how do their recommendations play out?
Oh, that's an excellent question, Allie, and something that we have evolved into over the last 18 months since standing up our primary care council. And they have a very strong presence on this group. In fact, I'll share with you that just a couple of meetings ago, we organized a panel of young professionals who are of the age range of 20s to 30s. And the significant majority of the meeting was spent on listening to what they had to tell us and asking them, what does telehealth mean to them? What does a relationship with a primary care physician look like to you? What are the barriers that you experience in trying to contact a healthcare provider? Do you care about it? Do you care about your confidentiality? And it was such an enriching and eye-opening experience. So we have put them front and center as a spotlight. And what we learned from this is going forward, this is really important for us to continue to inform the work that we do and the focus that we have in meeting patients where they are.
Wow, this is awesome. Thank you. I've never heard of anything like this, so it's really intriguing to me.
It's been a lot of fun. We're learning a whole lot about the true patient perspective of how they see and perceive healthcare.
Cool.
So another question for you. In many parts of the country and many systems in the country, the docs complain about the culture, essentially, of their organization that they find very controlling, that doesn't really respect their skills and abilities. And I'm getting the sense that you've created a very different culture, and I'm wondering if you could speak to that and some of the specific things that you do to create and sustain a culture that's more supportive and nourishing for your team.
Sure. So that is a very intentional move and purpose of our organization. We're very proud to be physician-led. And of course, this is a constantly evolving culture, and our health system is no different than others. We're not perfect, and we're learning as we go along. But what I will share is several years ago, there was a turning point in the organization where the health system recognized that there was a disconnect between physician leaders and administrators. And we made an intentional effort to change that. And in order to sustain that change, we developed infrastructure to allow us to constantly connect between a dyad, if you will, that's now become a triad. And sometimes we're adding more people to the table. So a sense of inclusivity has been really important to our group. We have a very active medical group from a leadership perspective. Every department has vice chairs with clearly delineated scope. We have developed an ambulatory quality and patient safety committee so that every vice chair of quality in the organization is connected to the purpose and the focus of quality in the outpatient space. So where oftentimes I've seen and experienced in healthcare organizations a separation, if you will, by departments, in particular in academic institutions, We feel it's very important to come together collaboratively, and where many outpatient quality metrics focus specifically on primary care, by bringing this group together, we have been able to identify ways that we all connect to the purpose of creating a healthier population, and by doing that collectively together. So that's one way we've done it, is by creating a dyad with our administrative leaders and our physician leaders, but now also adding, as I mentioned a moment ago, the triad structure. We are very closely tied now to our nursing leadership. So for example, while I represent the organization as the ambulatory chief medical officer, we have now identified a vice president of nursing for the ambulatory space. And we work arm in arm with one another to recognize that workflows overlap, and that by bringing in administrators to that clinical conversation, we have been able to support and clarify purpose for the entire healthcare team. So I'll share with you how we've created a curriculum calendar, if you will, based on those quality metrics and focuses of areas for us. And we, instead of focusing on 57 metrics every month with a report card, and everyone must focus on every single indicator at one time, we've broken them out month by month, so that the month before, the ambulatory team, which, as we mentioned a moment ago, is quite diverse and multidisciplinary in nature, we analyze the data and we look back by practice, and not just by department, by practice, to see where are those highest performers? What are they doing? Instead of us prescribing to them what success and high quality looks like, we ask them. And I find in our most functional practices, the response from the doctors is often a shoulder shrug, if you will. And well, I rely on my team to make that happen. And then when we press a little further, we're able to delineate usually one or two key drivers that makes the difference. And that has created success for us. I'll use the example of hypertension. While we recognize there's quite divisiveness around who agrees with which specialty on what the number should be for hypertension, instead of using a lightning rod to create arguments of why or why not we should focus on, for example, 140/90 for a well-controlled patient with hypertension, we instead focused on quality improvement projects, and it involves the entire staff. And in May, so we are in May now, our focus for this month is quality improvement. Each practice, because all of our internal medicine, pediatrics, and family medicine practices are level 3 PCMHs, we train them on PDSA and what that looks like. They're required to do 2 projects a year, and one of which is focused on high blood pressure. Another is of their choosing based on their quality performance and where they believe the focus needs to be. But for hypertension specifically, in May, we will walk through examples of what successful PDSA or Plan, Do, Study, Act cycles look like. But we have several tracks for this. We have one for the providers, and at our department meetings monthly in the family medicine department specifically, we invite all advanced practitioners, all the physicians, not just the physician leaders, and every practice manager as well as their leaders to be present. And when I first joined the organization, we may have had 20 people or so in the room. And at this point, we have over 50. And I don't even know how high the number is anymore, because they're engaged, they're focused. And for May, it will be specifically based on PDSA or Plan, Do, Study, Act for improving high blood pressure, and perhaps using other examples. And we have one that we'll share on diabetes as well. But then during that month, we'll also take this message specifically to our practice manager group, and we'll give them additional training on being Plan, Do, Study, Act or PDSA experts. And our practice chiefs, or that designated physician leader within the practice, will also be responsible for leading and facilitating in collaboration with their practice manager partner. And so that's the monthly department meeting. And then we have bi-monthly practice meetings where we go to the practice and we share in a transparent fashion what the performance looks like, provider by provider and by quality metric. So when we look at, for example, hypertension, if we see variation, we ask, well, tell us how you're so high performing in the area. What do you do, Dr. Smith? And oftentimes what we've heard is a simple focus. So for example, we've changed our language from focusing on less than 140 over 90, for example, and we're starting to use the number 139 over 89. So why does that make a difference? And it relates back to behavior. So we're all familiar with 140 over 90, and what we've learned based on the data that we analyze is we have a significant number of patients that are hanging out in the 140s over the 90s. And that's because we have this clinical inertia and we think, well, they're close enough. Maybe I'll give them another visit before I modify those numbers. And also, we are likely missing an opportunity on occasion to properly measure the blood pressure. So you're probably hearing in here a couple of examples of where they have decided to focus their PDSA efforts. But by changing that number to 139 over 89, all of a sudden, even a 140 or a 90 is no longer acceptable, and we're creating action. So again, it trickles from the high level of what's important to the health system based on what we're seeing in our communities and our risks, at the department level and consistency across the departments of our focus, and then at the practice level in partnerships with their teams focused on how they can relate and create their own solutions to their challenges. And then the following month, we bring that story back to the department level meeting to recognize those high performers. And oftentimes we have them share their own story. For one, it validates how important they are and how they're valued and their work matters. But then it also helps them focus and recognize, wow, we're doing some really cool things and taking good care of patients. And by the way, it also helps us with leadership development and creating a strength and speaking to their peers and developing solutions on their own.
That's fantastic. I'm wondering if you could share with us the results of this, some of the metrics. You're clearly very proud of your system, and it sounds like you have a lot of good reasons for that pride. Can you describe some of the performance metrics so we get a sense of just how much of an impact this is having?
I'd love to do that, Larry. And in the past several years, we have started our Medicare Shared Savings Program. I'll give the example of our upstate, if you will, Medicare Shared Savings Program. And our accountable care organization over the last several years has been able to dramatically increase performance across diabetes, hypertension, depression screening, and our breast cancer and colorectal cancer screening as well. In fact, we are in the 90th percentile for diabetes, and as I mentioned earlier, breast and colorectal cancer screening, and the top quartile for hypertension management. And our depression screening rates are well above the 90% level. So I'll share with you what we've been able to see. When I first got to Prisma Health about 3 years ago, our depression screening rates were in single digits or the low double digits at that point. And that has been through changing our workflow and engaging the entire healthcare team. What we've been able to do is increase our depression screening, as I mentioned, to well over 90% in all of our practices for our overall system. I'll also share with you a recent project that we focused on in this year specifically. We believe in bringing all primary care together, and by partnering with our pediatric colleagues, internal medicine and family medicine, we brought 30 individual practices into what we refer to as Flu Drive. And we brought them together to focus on the PDSA process. And as a cohort of 30 practices, sharing with them the best practices that they identified are those key drivers that made the biggest difference in their flu immunization rate. So just a year ago, none of our pediatric practices were vaccinating adults. And now a significant number of our pediatric practices offer it not only to siblings while they're there for their visit, but also the parents. We discovered our OBGYN practices. We brought them in as well. Before this year, they were only immunizing their OB or their pregnant patients. And we just kind of scratched our head, and we've learned a whole lot by connecting to other departments. But this year, they're immunizing everyone in their practice. They're, in fact, even immunizing partners that come in for visits. Family medicine has done the same, as well as internal medicine. Of course, we immunize the whole family, and where some practices focused initially on doing one flu clinic or a flu drive day, when they recognized how easy this was and to make it convenient for the families, they said, why aren't we just doing flu drives and flu clinics every day? It's just part of the work that we do. We also spent time working with them on the behavioral psychology of encouraging individuals to be immunized. So as the fruits of our labor, what we're seeing early on as we're calculating our data and finishing up the flu season is we have over 25,000 more individuals in our community vaccinated this year for flu than the year prior. And it's because of this work and the enthusiasm and the encouragement that we're sharing across all of these departments, and recognizing the greatness of when teams come together, how we are able to create a healthier community in front of us. It really has been an incredible experience.
Well, that is fantastic, and I congratulate you on that. I'm wondering if also you could comment, one of the things that's become clear in the COVID crisis for primary care is that the fee-for-service payment mechanism has woefully fallen apart with volumes down because of social distancing. And I'm thinking if your organization is farther along with value-based contracting, that perhaps that may not apply to you. But could you speak to that issue of what that's like when you're transitioning from fee-for-service into value-based payment?
Sure. And speaking specifically to the COVID-19 experience that I believe we have all had, we saw across the board a rapid drop in our volume mid-March as we hit the brakes to protect patients and to protect our team members from COVID-19 spread. And within a week, we recognized that it was critical for us to have our own internal telehealth platform. While we were attempting to partner with an outside vendor to serve these purposes, as I'm sure they were no different than everyone else, they were just overwhelmed with the volume they were seeing. There was a backup for hours for a provider to then connect with the patient later on. So we said, this is not working. And within 24 hours, our Epic teams, because we are an Epic shop, created the telehealth platform, and we trained all of our providers within 3 days on how to utilize telehealth. So
Wow.
while we have over 300,000 patients in value-based contracting, they're not in a capitated relationship with us. Being on the East Coast, we are still struggling with moving over from that perspective to full capitation, and it is more quality-based, cost savings-based. So we still live in both of these worlds, as we know we pay the bills in our hospitals with fee-for-service care. That is certainly shooting us in our other foot as we're trying to reduce that level of care. We've got a very strong care management resource within our system where we can recognize those who are at risk and engage them with care management. We are also standing up our CCM, or chronic care management support tools, with our patient-centered medical homes to pull these teams together. So we are building this plane as we're flying it and adding resources that we are learning to be effective. Another area of significant focus has been diabetes. And much like the rest of the South, we have a very high obesity rate, and metabolic syndrome is rampant. And so we are trying to address not only within our patient population, but community-wide, those patients who are at risk. We're utilizing community healthcare workers. We have a co-op relationship with Clemson University, where we are in our communities and educating and connecting with those before they even have diabetes. And then we follow that continuity through to help better manage those patients. We are now beginning to roll out remote control device management for patients, for example, with an A1C greater than 9. We are beginning to target those patients and connect them with resources to actively manage those glucose levels and sharing that information back to the patient-centered medical home. So I'm sure what many of us are experiencing are with the motivation of payers to have a healthy customer base, and for healthcare systems to have healthier communities, and for community organizations to be a part of that care. I find where we are becoming successful is partnering together to use those resources, and whoever is the expert in that space, recognizing that value and that talent, and instead of duplicating those efforts, tapping into that resource and better coordinating our care. Again, we don't have it all figured out, but we are moving in that direction and making great headway in teams and focusing on the collaboration within the health system and with our community partners.
That's great. I noticed in your CV numerous mentions of Tar Wars and Go Diabetes. I don't know what Go Diabetes is. I know what Tar Wars is, but clearly it speaks to your interest in prevention. Could you speak to that?
Yes, I've always had a passion for tobacco prevention and tobacco cessation. My father died at 50 years old due to tobacco-related diseases. And since I've been a medical student and resident, I've been aware of Tar Wars, and that is the American Academy of Family Physicians' original program for working with 4th and 5th graders to help them understand how important it is not to start smoking, and how much it costs, and how tobacco companies perhaps are trying to connect with our youth. And now with vaping, that's become even more relevant as we go forward. So that has always been a focus for me. If you consider tobacco-free environments a public health issue, I think it very much is. And now you asked about the Go Diabetes programming I've been a part of. When I was a family physician in Georgia, I partnered with the Georgia Academy of Family Physicians that reached out to residency programs and practices across the country to identify ways to better connect with patients from a process improvement perspective. So while we are taught and trained to treat diseases, where I believe we can benefit of additional learning is how to continuously improve the work that we do. I do believe that maintenance of certification lends itself to help us connect to a population and improve the care overall. And that's where I think sometimes as physicians we're lacking, and where assumptions are often made. Well, as the doctor, you must be the leader, and as the leader, you must know how to do this. But if we don't provide performance improvement tools or ways to be successful and how to continuously learn, then it's challenging to figure out how we really learn from those mistakes and use data and experiences to help us improve the care overall. So that is the drawn out response to your question about my passion for the community and how it takes these generic efforts to then focus specifically on the areas of need with tools that create a difference and a sustaining difference in those populations.
That's great. Thank you. So I'm going to ask a question. Actually, should have asked it way back at the beginning. I noticed on your CV that looks like your first graduation was from a community college.
Yes, so that lends itself to my meager beginnings. As I mentioned, I grew up in a trailer, and I wasn't familiar with an environment where people just automatically went to college. I didn't even consider applying anywhere besides community college because I received a scholarship. In fact, I put that scholarship money in the bank and covered a lot of my expenses with working at Kmart at the time to pay my bills, because I knew if I did get the opportunity to attend medical school, it would be overwhelming to consider the student loans that I would experience. And of course, that was many years ago before tuition was as high as it is today. But again, I didn't even apply to a university because I felt like this was the most cost-effective approach for me. And what it taught me was so much, and how I value the community college system to prepare students for the university setting. But not only that, the community college I attended had just a wonderful honors program that connected with students in smaller classroom sizes to help challenge us and grow us to think bigger, to think broader, starting at the community college setting.
Well, that is fantastic, and I have to say, Saria, you are an example, an exemplar for really the American dream is still alive.
Well, thank you. And, you know, it's interesting, just this year, I happened to come across the recognition of one of the first family physicians I ever came into contact with, and it was Dr. Robert Hatch from University of Florida. He was recently recognized for his legacy and lifetime of teaching skills through the Society of Teachers for Family Medicine. And I took a picture of that announcement, and I also snapped a shot of my acceptance letter to University of Florida, where he took the time to write a personal note to me. And I sent both of those messages to Dr. Hatch and just thanked him. You know, all of this time later, over 20 years of starting medical school, and the impact he has had on me as a family physician and his connection to individuals. I'm so grateful that the University of Florida gave me a chance and continues to give others an opportunity who perhaps don't come from families of doctors and lawyers and money or paid college to participate and be a part of the medical community in the way that I have been offered. It truly is an honor and a privilege to be a physician today.
Thank you for that. Allie, any final questions?
I'm just in awe of the story. And I was wondering, do you have any, I'll be going into family medicine residency next year, and I am overwhelmed by the possibilities of family medicine. Did you go into family medicine with a plan of wanting, what was your ultimate goal? Because there's so much that you have done, and there's so many avenues to take. What is some words of wisdom for people like me?
So, Allie, what I would share with you is anything is possible, and how contrite that may seem, but what I hope I send in what I do and how I message to individuals as role models, or how they look at what family medicine can be, is it's got to be your own story. And it took me some time to figure that out as a woman in medicine, as a family physician, where oftentimes we're looked over or passed upon, or you're too smart to go into family medicine, or, oh, you're just a family physician. And stay focused. Stay focused on what matters to you. What are you passionate about? That's what makes a difference. And everyone will have their own path. And honestly, that is one of the privileges of family medicine. You create your own path and be your own person. And if it's important to you, you'll find a way to make it work. And there are so many of us who are doing things so differently. Find those mentors that believe in you, support you, and challenge you to be your best self.
Thank you so much.
Words of wisdom, yes. Saria, I want to thank you very much for joining with us today, and we'll bring things to close. If you could stay on the line just a moment as I bring this to close. Thank you very much.
Sure. Thank you. It's been fun.